I'll be discussing about evaluation of ESR cell counter versus traditional methods. This is more of an academic based topic than a research based topic. And we've been using the BC 700 series for nearly 2 years now. We started off with the one without the autoloader. Now we're using the both, and based on that, I'm having this discussion. So, for a short introduction, we all know ESR, it's a widely used but non-specific marker for inflammation. It is the rate at which RBCs settle in an anticoagulated tube over an hour. It's a process influenced by plasma proteins, particularly fibrinogen and other acute phase reactants. The utility spans over various disciplines, including rheumatology and internal medicine, but it aids in monitoring and prognosticating numerous conditions. It's not diagnostic at almost all places. So, a brief about the history. It was first described by Edmund Biernacki in 1897, and later in 1921, when Westergren standardized the method, it came into clinical utilization. It has been staple test in labs for decades, but recent advancements are opening new perspectives how we approach this test. Because honestly speaking, as a pathologist who would have passed out in last decade only, the clinical applications and standardization of ESR was becoming more and more challenging. However, such technologies are making them easy and making quality control better for us. Talking about mechanism of ESR, there are three stages of it: rouleau formation stage, rapid sedimentation stage, and erythrocyte packing stage. So the rouleau formation stage is about 0 to 20 minutes, and rapid sedimentation stage is more than 15 minutes. So raised ESR is basically, in normal ESR is negatively charged, so it has a lower sedimentation rate, and during inflammation the RBCs are less negatively charged as plasma proteins, gamma globulins, fibrinogens negate this charge. So there is a increased sedimentation due to increased rouleau formation. Talking about the clinical utility of ESR, because so it's in managing chronic inflammatory diseases like rheumatoid arthritis, SLE, polymyalgia rheumatica, and temporal arthritis. So this is basically to monitor the fall in ESR, shows the treatment is working well and the inflammation is reducing. In infections, subacute and chronic infections, it has been our long friend in tuberculosis and one of the places where physicians still look at ESR. Rheumatology and tuberculosis are two applications where religiously ESR is still being used by physicians. Post-op monitoring, an unexplained rise in ESR may prompt further investigation. However, in clinical practice, I don't see surgeons and intensivists looking at this with that perspective. Oncologists, malignancies, yes, multiple myeloma, lymphoma, monitoring, oncologists are looking at really seriously, and sometimes in unexplained weight loss as well. Same in a few solid tumors like renal cell carcinoma. This is again useful in monitoring than diagnosis. Cardiovascular disease, it's a theoretical mention I have kept here because it was there in the text, but there's nothing clinically that is being done. In CKD, yes, it is being used by nephrologists regularly in monitoring inflammatory complications and comorbid conditions. Coming to the limitations, it's non-specific. This is the biggest problem this essay has. I remember as a first year PG, I was making a list of reasons why ESI is raised. I think I covered 2 full pages. So it's getting affected by so many things. It's not specific. So, and in many conditions such as anemia, kidney diseases, ESR is often raised even in the absence of inflammation. So it is not completely specific to the inflammation also always. Delayed response, ESR rise and fall is slow. Now parameters like CRP offer us a better sensitivity, or procal for sepsis, because their rate of rise and fall is faster. So ESR is not a good friend for acute conditions, but yes, it is a old friend helping still in chronic conditions. So limited use in early disease detection. External influences, it's a very sensitive parameter with increasing age. the ESR values rise. In women, the values are higher, and it even gets affected during menstruation. So for females in reproductive age group, this test is not so good. Anemia again increases ESR even in absence of inflammation, and honestly, in a clinical context, if I speak, a majority of patients who are presenting with tuberculosis are actually anemic also, because TB is now more in the low strata. So, and certain medications also, like statins and steroids, alter ESR by influencing red cell aggregation. So these were the technical limitations, but the practical ones are that it's a subjective assay. The test is completely manual. It is operator dependent and environment dependent. So no matter how simple it may look, but we are completely reliable on technicians to fill the tubes properly and read it at exactly 1 hour. And it's become more challenging now, because with everybody having mobile, half the time the technician who's on duty is waiting while he's put the timer. Earlier he used to use the timer in the lab, now he uses his mobile and is seeing the reels. So whether he's reading at 1 hour plus minus 1 minute, it's really no way we are able to assure that. So it has reduced sensitivity in certain diseases. There it may remain normal despite the presence of inflammation. So for in SLE, where it has a very good application in looking at flare-ups, but it still remains normal sometimes. In AMI, ESR elevation is delayed, so it's the person will pass away, so we don't even look at it for that matter. So talking about the reference range, for males above 50, it is less than 20. Males less than 50 is less than 15, but a practical range is age less than 12, age divided by 2, sorry. For females above 50, it is less than 30, and for females less than 50, less than 20, but a practical reference range would be age plus 10. Special mention is markedly elevated ESRs more than 100, because ESR may have a lot of non-specific rises very often in general health checkups or CBC ordered for random, for any other reason. The raised ESR of 30, 40, clinicians often ignore, but ESR more than 100 actually warrants immediate attention. So what can be the conditions? Severe bacterial infections like pyelonephritis and sepsis, autoimmune vasculitis, malignancies like multiple myeloma and metastatic cancers, and connective tissue disorders, severe flares of SLE or rheumatoid arthritis. Now, this is where ESR was losing its significance, that on one side, an SLE, a flare up, it can go as high as above 100, but in few cases, it remains low. Now, as a laboratorician, it becomes a problem, because clinician all does not remember the pitfalls of the test. He just thinks that every time my finding is not matching up, lab has made an error. So talking about evaluation through traditional methods, we all know the Westergren method. It is the ICSH reference method, a 30 mm long tube with 2.5 mm bore open on both sides at 18 to 25 degrees Celsius with sodium citrate of 4:1 dilution. We can use EDTA also as an anticoagulant, so that's called a modified Westergren. That's just for everybody knows that. And Vintrobe, it just uses a smaller tube, 11 centimeter long with 2 mm bore, and can also be used for PCV. Now the limitations in traditional method is that it's time consuming, requires 1 hour to complete the test, which may be a limitation in acute care settings and where urgent reports are needed. Further, the time consuming is not just about conducting the ESR, it is complete comprehensive TAT of the patient, because CBC, for instance, the analyzer is taking 60 seconds, but it takes us an hour to give out even an urgent report. Likewise, the same in hospitals or big institutional setups, they are segregated labs, so multiple EDTAs may be collected. But for standalone labs, especially preventive health checkup, which form 25% of laboratory business by all data, we are just collecting one EDTA. So that the same EDTA we have to run CBC, then we would perform an HbA1c on that, and then it would go for ESR. So that really has a big impact on comprehensive turnaround time for us. Manual errors are immense because again the labeling is completely manual. You are writing on a sheet across the stand. You have numbered the sheets. So there's in the current laboratory methods, we are moving more and more towards, we are almost completely at barcoded systems. So this is a human error is very high. Temperature sensitivity, sedimentation rates are very sensitive to temperature. And when we are looking at results, we are not just looking at results coming from our lab. It's not about, we have to answer to the clinicians. Say Pankaj sir was here, he's talking about Palwal. In Delhi, I don't have neighborhood of such labs, but in a place like Palwal, he would have a lot of people around which are unregulated labs run by technicians in one room who, would have a AC to probably run their CBC analyzer, but for ESR, they will never turn it on. And when those results come up, the doctor is asking us why they don't match. So, anticoagulant issues, improper mixing of blood with anticoagulant, but that's sorted now with the tubes, and operator dependence and quality assurance is a big challenge in a traditional ESR. Coming to automated ESR systems, the first line of automated ESR systems which came were modified Westergren automated systems. So they generally what they do, they let the agglutination stage go on, because the sedimentation stage, it is a well-defined factor that rapid sedimentation happens at the same pace. So they let the agglutination phase get completed, take a reading in the early sedimentation phase and calculate the net ESR value. However, now we are looking at capillary photometric ESR systems or a near infrared photometry technology which Mindray BC700 series is using. So it is not relying on traditional sedimentation, but it assesses the erythrocyte aggregation in a small volume blood sample using optical sensors. So these systems, they are actually calculating ESR within first 5 minutes, say for Mindray it's 72 seconds. How they are doing it is they are doing it right in the aggregation stage only during the rouleau formation. So the Mindray BC700 series, I really take it as a boost for laboratory functionality. Single tube automated CBC with ESR. It's called a easy WESR technology. 72 seconds. It has really changed a lot of functioning in my lab. So the principle is that the rapid sedimentation stage, as I was mentioning, falls down with a constant speed. So which in turns, at the speed they will fall on, it depends upon the erythrocyte aggregation state in rouleau formation. So over here they are using a dynamic curve to predict the 1 hour fall. What are the key factors it is using? Erythrocyte aggregation speed. What it's doing, the speed at which erythrocytes are clumping together is equal to the time required for the aggregate to form, and once this stage is complete, then it would go to sedimentation. So faster the aggregation is happening, there's early start of sedimentation and high ESR. That's where the red line is for the high ESR, as the sedimentation was happening faster. To achieve this technicality, there's one thing more they needed is the erythrocyte aggregation degree, because at the end when it's falling against free flow with the gravity, it would fall at a constant speed which depends upon the size of aggregate, which determines which would be determined by the degree of aggregation. For this, they have created a complete disaggregation of erythrocytes by high velocity laminar airflow, which is putting red cells in a shear pressure under shear pressure, where it disintegrates any previous aggregation which may have happened in the samples. After that, it suddenly stops to capture the peak aggregation speed so that they come to normal morphology and start reaggregating. And that's where it takes the measurement of the aggregation happening. Then the aggregates are looked, and they have a temperature module which ensures constant temperature. So the machine first is preparing the samples by the 3 steps I explained, and then through the light source they are looking at the aggregation speed. Now what it does, it has taken 2 measurements: aggregation speed, which tells the sedimentation start time, aggregation degree, which tells the sedimentation speed it is going, and it would put it into a distance curve which would measure the value and give out. Clinical performance, as per the company, it has a 0.94 correlation. However, the same claim was performed by clinical validation by Dr. Kunal in India. 2 years ago, when we brought this and started reporting, we had done our validation with over 200 samples and we had found complete correlation of almost all values. To talk about a comparative analysis of ESR manual methods, automated methods and the ECW-ESR, it is the fastest amongst all. It has the lowest interoperable variability. Pre-analytical sensitivity is less because the scope for pre-analytical errors, because it's a primary tube sampling, barcoding and interface. So post-analytical errors also it is taken care of. The main question comes with technology is the cost. But if you ask me, in my 2 years of experience, by removing the traditional or the Westergren based, automated Westergren based ESR system which we were previously on, this is costing us much lesser when I account for manpower cost also. So advantages which I have seen in my lab, the TAT is faster, reduced human error, single tube assay, primary tube, barcoding and interfacing, reduced manpower requirement since it's a walkaway system, accuracy is better, space saving for standalone labs, space is a big decision, and definitely it gives us a better quality control and quality assurance. For the patient, we are not having to need extra blood sample, faster result. The wonderful part is, as ma'am was also talking about, neonate and pediatric and other low volume samples. We do a lot of work with NICUs and pediatric patients as well, but we were doing TNP for all ESRs over there because we never had enough volume to even perform on a Westmatic system. Urgent reporting is possible, and now the patients in serial monitoring who are undergoing treatment for tuberculosis or SLE or rheumatoid arthritis, the comparability is much better. So in my experience, I have actually seen zero errors as a primary tube sampling. In last 2 years, I have actually not received a clinician call me back and say, I am not happy with your ESR result. So that's a big marker. I looked back when they asked me to have this talk, I looked back at my data of all the customer complaints and queries which come. None of them were with ESR. QC, QA and accreditation has become much simpler. My neonatologist is happy, my pediatrician is happy because they have this parameter which I was unable to report to them. And pediatrics is a special area, so the kids are happy with us, we are able to do. So from my end, it's a 5-star parameter, equipment and performance. Thank you everyone.